This is a list of 10 things that you want to think about when you're thinking about embarking on an integrated care journey. There's no magic in the number of 10, it's just usually lists like this have the number 10 in them, so I thought I'd better find 10. As I mentioned at the outset, the burning platform for change. In your local health system, what is the burning platform? What is a common rallying point? What is some common interest across the system that people can relate to as a problem? Most people are not even aware of the problem, depending on where they sit. So a whole lot of energy needs to go into defining a problem and then telling people about the problem. And enlisting the key opinion leaders, the movers and the shakers, the influencers in the system, who are going to have to share both the problem and the solution. They need to be enrolled in a shared view of what the burning platform is early on. Secondly, develop a vision of, if we manage to put the fire out, what does that look like? And how are we going to do that? What's the strategy at a high level? What are the goals that will contribute to that burning platform being sorted? And particularly think about those in patient and population outcome sense. Ultimately, this is all about doctors and nurses and other health professionals working differently. So this is about clinical leadership. Nothing is going to change unless doctors and nurses and allied health people agree to work differently and agree to give up something for the greater good. So this is about enrolling clinical leadership and giving it roles, giving it a mandate, putting it into structures within which clinical leadership can actually lead. Fourthly, this is the culture thing. This is the need to develop a culture that fits with clinical leadership, that fits with the long-term vision, that fits with the burning platform. This is about new relationships, it's about new ways of thinking, new ways of working, and it's about communications. This is telling the story over and over and over and over and over and over and over again until people actually start to identify with it and can, when you run into somebody in the corridor, they can actually tell the story back to you. I'm not sure if you've ever seen anybody from Canterbury DHB telling the post-earthquake story. So this is the Christchurch earthquake. One thing that Canterbury has done fantastically is telling the Canterbury story. It gets a bit boring when you get to hear it every day, but people at the coalface, right through to the chief executive, will tell the same story about what they're doing and why. It's a remarkable achievement. And they actually believe it. That's one of the really scary things. Then you've got to design the future model of care. What's the model of care that's actually going to make a difference to the burning platform? And again, there's a lot of literature, a lot of learnings about integrated care to call on for this. You don't need to start from scratch. It's a really good idea to beg, borrow and steal ideas from elsewhere. Adjust them to fit to your local environment, but there's no need to start from scratch. But whatever model you end up with, it's going to be centred on primary and community services. That is going to be at the core of the model, and it's about multidisciplinary teams with the individuals in it working at the top of their scope of practice. It's asking GPs to step up, it's asking nurses to step up, it's asking allied health to step up, and it's inventing some new roles in the workforce to whom tasks can be delegated, which don't need high skill levels. And really importantly, it's about getting specialists to understand that a large part of their role is supporting primary and community care. Yes, they've got an ongoing task with really sick patients in the hospital, because inside this model, the patients who do hit the hospital are going to be sicker. The easier ones are not hitting your hospital. So you're dealing with sicker patients in the hospital, but a lot of your job is to support primary and community care. Funding and contracting. How do you incentivise and reward the behaviours that you want? and how do you get rid of the perverse incentives? Really important, and I think a big challenge inside the Australian system right at the moment. Number 7, as I said, advance on many fronts at once. What you're trying to do is to get a critical mass of activity going on that in a cumulative way is going to have a big impact. Otherwise you are stuck at the margins and you'll run really successful little micro things that actually make no difference to anything in terms of outcomes or resource utilisation or changing the culture. So you need a whole lot of linked initiatives going on. Over time you can drop the things that don't look like they're working so well, you can take on new things, but you need a scale of response that matches the scale of the problem, or else you're not going to impact on the problem. KPIs and targets, so this is about a small number of indicators at the whole strategy level, so you can report back to people that the big picture's working, and then inside each initiative you have a set of KPIs and targets that roll up to the aggregated view. And really important because of the clinical variation picture to have utilisation review and feedback going on. As we all know, it has a massive effect on clinical practice, but unless you're capturing that information and feeding it back in a timely way and have some sort of peer review environment wrapped around it, you're not going to get the value out of it. IT, that's a whole discussion in itself. But if you want coordinated care, if you want case management, if you want a whole of system approach, then shared electronic medical records or just a summary of them, plus sharing particularly of the care plan, for the small cohort of the high-risk patients. Everybody having access to that care plan is really important. And last but most certainly not least, it's a long journey, and getting started is the most difficult step. People need to understand it's a long journey, that this is the new way of working. It's not going to be a destination that we reach within a couple of years and life returns to normal again. This is the health system of the future, and it becomes just the way of working around here. And if you go to Canterbury, they've got that story. You go to Counties Manakau, they've got that story, that this is the way the health system works around here. As I mentioned in my update of where things have got to since 2010, you've got to keep on reinventing it and revitalising it and refreshing it. But it's just, this is the way we do things around here. So I'll stop there.